Okay, so today we're going to talk about inflammatory bowel diseases, or IBD. So IBD includes Crohn's disease and ulcerative colitis. Okay, Crohn's and ulcerative colitis, and we have to be able to distinguish between these two. So in terms of risk factors for IBD, it's more common in Caucasians and Ashkenazi Jews. Okay, just remember Caucasians and Ashkenazi Jews. And it's common in patients who are less than 30 years of age, so relatively young individuals. And the use of NSAIDs and OCP, so oral contraceptive pills, can actually be a risk factor for IBD as well. So there are extra intestinal manifestations of IBD. So IBD, although it's an inflammation of the bowel, the inflammation can occur not just in the GI tract. The inflammation can manifest in the eyes or in the skin. So in the eyes, for instance, patient can have anterior uveitis or iritis. So uveitis obviously is the uvea, and iritis is the inflammation of the iris. So it can lead to B12 and iron deficiencies. Okay, this is because of the malabsorption that happens in the bowel when you have inflammatory bowel disease. Okay, B12 or iron deficiency. Erythema nodosum. So this is a dermatological manifestation of IBD. So erythema nodosum. These are red, painful lesions in the legs. So you can see it here. So this is erythema nodosum here at the top. So erythema nodosum, again, are painful red lesions on the legs. And these basically is inflammation of the subcutaneous fat in the patient's leg. Okay, this is not specific for IBDs. Actually, this can be found in leukemia, for instance, even in sarcoidosis. So ulcerative colitis and Crohn's as well. So it's not just it's not pathognomonic for IBD. It's just it can be seen in IBD. So remember erythema nodosum. The next one is pyoderma gangrenosum. So pyoderma gangrenosum is this. So as you can see, this is again painful ulceration. It's not just like a nodule. This is ulceration in the lower legs that can lead to necrosis. So pyoderma gangrenosum, this painful lesion on the leg that can lead to necrosis. So again, just to recap, IBD, in terms of risk factors, Caucasians, in terms of age, it's usually age in the younger generation, so less than 30 years of age, and medications or contraceptive pills and NSAIDs would put you at the risk of IBD. And it has extra intestinal manifestations, so it can affect the eyes, causing anterior uveitis or iritis. It can have dermatological manifestations, so like pyoderma gangrenosum, this ulceration, painful ulceration in the leg that can lead to necrosis, and erythema nodosum, which is the inflammation of subcutaneous fat, leading to these painful red lesions usually found on the legs, and B12 and iron deficiency because of the malabsorption. Okay, so just remember those extra intestinal manifestations. So again, in the eyes, you have iritis and anterior uveitis, skin, pyoderma gangrenosum, and erythema nodosum, and in terms of malabsorption issues, B12 and iron deficiency. Okay, so moving on to Crohn's disease. So remember that inflammatory bowel diseases, they have different types. So we have Crohn's and we have ulcerative colitis, which we're going to talk about today. So Crohn's disease, starting with Crohn's disease. So Crohn's disease is an autoimmune inflammatory bowel disease. It has a relapsing and remitting course. So we already know it's an inflammatory bowel disease. It's autoimmune, and it has a relapsing or remitting course. So we have to be able to distinguish Crohn's disease from ulcerative colitis. So Crohn's disease, the inflammation in the GI tract is usually transmural. Okay, transmural meaning affecting all layers of the bowel, the GI tract. It's not limited only to the mucosa and submucosa. So in the case of ulcerative colitis, the inflammation is limited only to the mucosa and the submucosa. With Crohn's, the inflammation is transmural, okay? Transmural. So with Crohn's disease, it can affect any part of the GI tract, okay, from the mouth to the anus. So any part of the GI tract can be affected in Crohn's disease. That's very key. But typically the rectum is spared, okay? In the case of ulcerative colitis, it's kind of the opposite, because the rectum is always involved in ulcerative colitis, and it typically is only limited to the large bowel, okay, to the colon. Okay, so the most common area to be affected is the terminal ileum, okay, the terminal ileum. So how do I remember that in Crohn's disease the most commonly affected area is the terminal ileum? So I think of the rapper called T.I. So this is probably an old rapper now, and I say T.I. makes CDs because, you know, he makes his own music and stuff. So T.I. stands for terminal ileum, and CD, Crohn's disease. So T.I. makes CDs, terminal ileum, Crohn's disease. Okay, so just to recap, Crohn's is an autoimmune inflammatory disease of the bowel with relapsing and remitting course. It can affect any part of the GI tract from the mouth to the anus, and the inflammation is transmural. It's not limited only to the mucosa and the submucosa, and rectum is typically spared. The most common area to be affected is the terminal ileum, okay? TI makes CDs. In terms of symptoms, we can see right lower quadrant pain. Why? Well, if you think about it, the terminal ileum is located in the right lower quadrant. So this is why they get right lower quadrant pain, because the terminal ileum is the most common area to be affected in Crohn's disease. Diarrhea. In terms of diarrhea, they're gonna have diarrhea, but it's gonna be non-bloody diarrhea. There's no blood in the diarrhea. And lastly, they may present with weight loss, okay? Again, because of the malabsorption that happens, they can present with weight loss. So right lower quadrant pain, non-bloody diarrhea, and weight loss. So how do I remember everything I need to know for Crohn's disease? So Crohn's disease, CD. So I say CD, C, completely diverse. So all the C's are completely, and then the D is like the characteristic. So CD, completely diverse. What do I mean by completely diverse? It can affect any segment of the GI tract from the mouth to the anus. Completely diverse. So it can affect any portion of the GI tract. Completely deep, because it affects all the layers of the GI tract, okay? Not just the mucosa and submucosa, as in the case of ulcerative colitis, okay? Through all the layers of the mucosal membrane, completely dry. So this pertains to the fact that these patients have non-bloody diarrhea. So their stool is dry, okay? And completely discontinuous. So completely discontinuous because they have non-continuous lesions. They have like skip lesions, which actually we'll talk about in the diagnostic part. So they have skip lesions, the inflammation is discontinuous, okay? So again, Crohn's disease, CD, completely diverse. It can affect any segment of the GI tract from the mouth to the anus. Completely dry, pertaining to non-bloody diarrhea. Completely deep, pertaining to the fact that the inflammation is transmural, affecting all layers of the mucosal membrane, not just limited to the mucosa and the submucosa. And completely discontinuous because of the presence of skip lesions, which actually is a diagnostic test, okay? So that's everything you need to know for Crohn's disease, okay? Okay, so now how do we actually diagnose Crohn's disease? So for diagnosis of Crohn's disease, the first thing we could do is an upper GI series. An upper GI series is basically an imaging test of the upper part of the GI tract, so the esophagus, the stomach, and the first part of the intestine. And this is done with like x-rays after swallowing a beverage that contains barium contrast. So you ask the patient to swallow this beverage with barium for contrast, and then you do this upper GI series, an imaging test that uses x-rays. Okay, so you can visualize the esophagus, the stomach, and the first part of the intestine. So with this upper GI series, what you're gonna see is called the string sign. So this is the string sign. So if you can see here, that has like a narrowed area of the bowel. So if you see, here is like normal diameter of the bowel, and so is here. But here in the middle, there is that narrowed area. And this, it kind of looks like a string. This is why it's called the string sign. And this string sign, that indicates the areas of the inflammation. Okay, so as you can see, normal bowel, and then the string sign, areas of inflammation, then again normal bowel, again highlighting the fact that this is a discontinuous inflammation or a discontinuous lesion. Okay, the next thing you can do is colonoscopy. So in colonoscopy, again, you're gonna see essentially the same thing, discontinuous inflammation. So this will present as when you do colonoscopy, you're gonna see areas of normal bowel, and then areas of inflammation, and then again normal areas of the bowel. So you get this alternating areas of inflammation and like normal portions of the bowel. Okay. Also on colonoscopy, you can see this cobblestone appearance. So this is very important to remember. So string sign when you do upper GI series, and cobblestone appearance, because they're going to ask you this in the exam. So colonoscopy, you need to know cobblestone appearance. So it would, the bits where there are inflammation, you're gonna see this kind of appearance on colonoscopy. So it kind of looks like cobblestone, so that's why cobblestone appearance. Okay. The next thing you can do is a biopsy. Okay, so if there is any uncertainty with the diagnosis, you can always do a biopsy. And in the biopsy, what you're gonna see is transmural inflammation. So inflammation of all layers of the membrane. Okay, not just in submucosa and the mucosa. It's a transmural inflammation. What you can also see is non-caseating granulomas. Okay, non-caseating granulomas. Again, this is not specific, but it's what you're going to see when you do biopsy. And the last one is creeping fat. So creeping fat, basically fat that kind of migrates in the areas of inflammation. So these areas of inflammation are going to be covered in mesenteric fat. And this mesenteric fat kind of migrates to that area where there's inflammation. Okay, so that's for the biopsy. Transmural inflammation, cobblestone appearance, transmural inflammation, non-caseating granuloma, and creeping fat. Okay. In terms of labs, so what kind of labs would you get to help support a diagnosis of Crohn's disease? Well, you're gonna get ASCA. Typically, these patients are gonna be ASCA positive. Don't think too much about it, just think ASCA positive. And obviously, because Crohn's disease can lead to B12 and iron deficiency, on the labs, they might it might show B12 and iron deficiencies. Okay, so just to recap in terms of diagnosis, the first thing that you're gonna do is an upper GI series where you ask the patient to consume this beverage containing barium contrast, and then you visualize the upper part of their GI tract, so the esophagus, stomach, and the first part of the intestine using x-rays. Okay, in this imaging study, what you're gonna find is the string sign. So there's this narrowed portion of the bowel in between two areas of normal bowel, and this narrowed portion pertaining to the string sign is the area where there's inflammation. Okay, next thing you can do is a colonoscopy. On colonoscopy, what you're gonna see is like alternating inflamed area and normal areas of the bowel. So inflamed area, normal area of the bowel, inflamed area of the bowel. Okay, and you're going to see the cobblestone appearance. So in the areas where there's inflammation due to Crohn's disease, you're going to see this cobblestone appearance. And the last thing you can do if there's any uncertainties regarding the diagnosis is a biopsy. So on biopsy, you can see three things mainly. So the first one is transmural inflammation. Okay, so inflammation that's not just limited in the mucosa and submucosa. It's transmural inflammation affecting the whole mucosal layer. Okay. The next one is non-caseating granuloma, and the last one is creeping fat, which is mesenteric fat that migrates to the areas of inflammation. Okay. In terms of labs, ASCA positive and B12 and iron deficiencies. So that's pretty straightforward for diagnosis. In terms of treatment, how do we treat Crohn's disease? So to treat Crohn's disease, it depends on the severity of the disease. So if we have a mild Crohn's disease, okay, mild Crohn's disease, you can give them 5-ASA. So ASA is a acetylsalicylic acid. It's essentially aspirin, okay? And 5-ASA is just like a different form of aspirin. Aspirin, obviously, we know is an anti-inflammatory, right? And Crohn's disease is an autoimmune inflammatory disease of the bowel. So we give an anti-inflammatory 5-ASA. A more specific one is mesalamine. So mesalamine is type of 5-ASA, okay, mesalamine, or glucocorticoids. So if they are like intolerant to 5-ASA, you can give them glucocorticoids. In severe cases or in refractory cases, you can give them immunosuppressants. So immunosuppressants like methotrexate and infliximab. So infliximab is a TNF agent. Methotrexate is an immunosuppressant. So methotrexate or infliximab. And surgery can be used, but it's not curative. Okay, surgery is not curative for Crohn's disease. That's very important to know. Surgery we only do as like a symptomatic relief. So this is typically just like palliative care. So if someone has a really severe case of Crohn's disease, and it's really causing a lot of inflammation and problems in that patient, we can resect that portion of the GI tract that is severely inflamed. But like I said, the fact that Crohn's disease, okay, is a discontinuous lesion. So to be able to use surgery effectively for Crohn's, we have to remove the entire GI tract, which is not really possible, you know. So surgery we do for Crohn's only for symptomatic relief, only for palliative care, okay. It's just to take out that part of the GI tract that is causing a lot of problems with the patient. So that's it. So again, treatment for mild, you can give 5-ASA like mesalamine or glucocorticoids. For severe or refractory cases, you can give them immunosuppressants like methotrexate and infliximab. Again, for palliative or just symptomatic relief, surgery can be used, but surgery is not curative for Crohn's disease. Okay, so moving on to ulcerative colitis. So ulcerative colitis is the other kind of type of inflammatory bowel disease. So we've talked about Crohn's disease, and now we're going to talk about ulcerative colitis. So ulcerative colitis is again inflammation of the bowel. It's an inflammatory bowel disease, and the inflammation is typically limited to only the colonic mucosa, okay, to the colon, the big intestine. So it only affects the mucosal and submucosal lining of the large intestine. So you can now see the differences between Crohn's and ulcerative colitis already. It's limited only to the colon, and the rectum is always involved, okay, always involved. And the inflammation is continuous, okay, inflammation is continuous. Symptoms: bloody diarrhea, abdominal pain, but in this case now, the abdominal pain is on the left lower quadrant, okay, because the colon, okay, is in the left lower quadrant, okay, for the most part. Okay, so they can also experience something called tenesmus. So tenesmus is this feeling of incomplete bowel emptying or incomplete defecation. And this is just because of the inflammation of the bowel, inflammation of the rectum. It gives that sensation that you haven't completely emptied your bowels, although you have tenesmus, okay? So, okay, how do I remember everything I need to remember first? Well, not everything, but for the most part. Ulcerative colitis. It starts with ulcer, so ULCER. U, usually limited to colon, especially the rectum. Usually limited to colon, especially rectum, ulcerative colitis. Also in the name, colitis is inflammation of the colon. So that's how I remember that ulcerative colitis is only limited to the colon, and especially the rectum. Okay, so usually limited to colon, especially rectum. Okay, so now you can see the parallels between ulcerative colitis and Crohn's disease. So just to review, ulcerative colitis and Crohn's, they're both inflammatory bowel diseases. Crohn's has a relapsing remitting course. Ulcerative colitis, in terms of characteristics, it's limited to the colon. Okay, whereas Crohn's disease is completely diverse. It can affect any segments of the GI tract from the mouth to the anus. Ulcerative colitis, the rectum is always involved. Actually, rectum especially is involved. In Crohn's disease, the rectum is usually spared. Okay, in ulcerative colitis, the diarrhea is typically bloody, whereas in Crohn's disease it's completely dry, so the diarrhea is non-bloody. In ulcerative colitis, the inflammation is limited only to the submucosa, in the mucosal lining, whereas in Crohn's disease, like we've already discussed, it's completely deep, so it's a transmural inflammation. And the last thing to know is that in ulcerative colitis, the inflammation is continuous, whereas in Crohn's CD completely discontinuous. Okay, so in Crohn's we have skip lesions. In ulcerative colitis we don't have skip lesions. It's continuous inflammation. And in terms of symptoms, obviously we have the bloody diarrhea, we have abdominal pain but localized in the left lower quadrant, and tenesmus. Tenesmus again is that feeling of incomplete defecation, and this is because of the inflammation of the colon and the rectum. Okay. Okay, so in terms of complications for ulcerative colitis, it's a risk factor for colon cancer because of this repeated inflammation in the colon. It can lead to colon cancer, unfortunately, and it can lead to primary sclerosing cholangitis, which we will discuss at a later date for the GI topics. So it's a risk factor for colon cancer, for primary sclerosing cholangitis, and for toxic megacolon. So toxic megacolon happens in really severe cases, and patients would show signs of toxicity. You know, they would be tachycardic, they would be hypotensive, things like that, and the patient would look really, really ill. Okay, so colon cancer, primary sclerosing cholangitis, and toxic megacolon are the complications of ulcerative colitis. So in terms of diagnosis, what we could do is flexible sigmoidoscopy. So in flexible sigmoidoscopy, the ulceration and inflammation would be seen in a continuous pattern. Okay, so flexible sigmoidoscopy, ulceration and inflammation is in continuous pattern. There are no skip lesions, there's no cobblestone appearance. Okay, barium enema is the next thing, another thing we can do actually. So in barium enema, there would be complete loss of haustral markings. We see this lead pipe or stovepipe sign. So if you see here on this side, here you see that there is that haustral markings, you know, the lines in between the segments. And here you see the loss of haustral markings. So it kind of looks just like a continuous pipe. So this is where that lead pipe or stovepipe appearance comes from. Lead pipe or stovepipe sign seen in ulcerative colitis when we do barium enema. Okay, so in terms of labs, it's positive for P-ANCA. So remember that in Crohn's is positive for ASCA and B12 and iron deficiency. For ulcerative colitis is P-ANCA positive. Okay, P-ANCA positive for ulcerative colitis. So okay, just to go over that again, so the complications of ulcerative colitis, because remember it affects the colon, okay, solely the colon and especially the rectum. So with repeated assault, with repeated inflammation to the colon, that can lead to colon cancer. And primary sclerosing cholangitis is another complication, and toxic megacolon. In terms of diagnosis, we can do flexible sigmoidoscopy. We're gonna see continuous inflammation. Okay, no skip lesions, no cobblestone appearance. On barium enema, This is another thing that they like to ask, because the specific name for that sign is the lead pipe or the stovepipe sign. That's the loss of haustral markings on barium enema. And labs positive for P. ANCA, whereas Crohn's is positive for ASCA and B12 and iron deficiency. So treatment is kind of similar, apart from surgery, because here surgery would actually be curative. Whereas in Crohn's disease, we only do surgery as symptomatic relief, usually for palliative care, okay, because it's non-curative, because it can affect, any portion of the GI tract. So that means resecting the entire GI tract, which is impossible. So in ulcerative colitis, surgery is curative, because you only have to resect the colon and the rectum, which are involved in ulcerative colitis. So again, for treatment, if it's mild, 5 ASA, so mesalamine, for instance, mesalamine. Glucocorticoids can be used in more severe cases, and in really severe cases, we can resect that portion of the colon and the rectum that is inflamed. And this is reserved for severe cases and refractory cases, refractory to 5 ASA, mesalamine, and refractory to like glucocorticoids or something. And surgery is curative. So again, 5 ASA, glucocorticoid surgery, which is curative.